There are several different things that you can look at for risk stratification. The one with the most evidence is the Mantle cell Prognostic Index, or the MIPI. This takes 4 clinical risk factors, which include age, LDH, leukocyte or white blood cell count, and performance status, and calculates the prognosis of outcomes and divides them into 3 groups: low, intermediate, and high risk, with patients with high risk having an overall survival of only 29 months. So this has been validated with a number of different treatments, both in younger and older patients, more aggressive and less intensive approaches. The MIPI is nice in that it is prognostic with all these different factors. What the downside to the MIPI is that it doesn't really help you decide therapy. So we don't use it to decide if a patient needs therapy. A patient that's symptomatic, has bulky disease, has bad blood count, is going to need therapy regardless of their MIPI score. And a patient, you're going to treat them more based on their age and comorbidities as far as deciding therapy than you are going to treat them based on MIPI. Now, there are a small number of patients who are maybe in age range or have comorbidities that you're not quite sure if you want to use or should use a less intensive or more intensive approach. And in that setting, sometimes I may let MIPI decide. If I have a patient who's borderline age for intensive therapy or transplant, I may say, if they have low risk MIPI, that I'm going to use a less of an intensive approach in those. But largely, it's more prognostic.